So welcome again to an episode of the Train the Trainer podcast, in which I try to bridge the gap between science and practice and science, and for the military and the emergency medicine and police teachers, instructors, and of course the operators themselves. Today, for me, a special guest. His name is Michael Lauria. I hope I pronounce it good, Lauria. And he was a para-rescue man in the US Air Force and critical care flight paramedic for the Dartmouth Hitchcock Advanced Response Team. And I hope this is actual now still. He's an emergency medic and physician at the University of New Mexico Health Science Center, EMS Critical Care Fellow, Flight Physician, and the Associate Medical Director for Lifeguard Air Emergency Services. There's a lot of air in that, a lot of flight.
There happens to be a lot of air in there, yeah.
Yeah. Well, welcome, Michael. And I told you before we recorded it that I and my colleagues from the ambulance and emergency medicine, we stole your Beat the Stressful acronym some 5 or 6 years ago because it was such a practical acronym for dealing with stress, and we followed your work since then. So
No
thank you
problem.
for
Steal
yeah.
away.
Yeah. So can we just start there, Michael, with what is a para-rescue man, and what did you learn there? I'm not
Oh,
sure
so
if we
great
have it.
question.
Yeah, I'm not sure what it is called in Holland. I'm not even sure if we have para-rescue teams, but maybe I'm wrong.
Yeah, so it's actually a lot of other nations and militaries don't necessarily have an exact parallel, but there are similar organizations that kind of fulfill the same role. So our job was primarily to provide technical rescue and medical rescue services to various special operations organizations. Originally was designed for it's through the Air Force. It was like pilot recovery, especially in Vietnam, where the organization really began to um, gain notoriety for the amazing rescue work that they were doing in Southeast Asia. And
Hmm.
then since then has sort of matured and evolved in line with the special operations community to provide essentially very austere and in tactical environments, rescue, recovery, and medical services, which is pretty cool and very unique. The mission is, in fact, very unique, and then part of the evolution of that, both um, in combat and outside of combat, has been to be able to perform those services, essentially all over the place and in every environment we could possibly imagine. So that incorporates a lot of special skills like parachuting and diving and a host of others that are somewhat unique for a single team and or organizational specialty. At least in the U.S. military and certainly across military. So it's an awesome organization that continues to evolve and um, one that absolutely taught me a lot. So
And is it the same as tactical medicine, or is it broader?
it does, and I would say it's a little bit broader. So it incorporates tactical medicine, but it also incorporates prolonged field care and austere critical care and a whole host of along the spectrum of emergency medicine and critical care.
So if I'm correct, you had to be a soldier and a medic at once.
Correct. Yep.
Yeah. Okay, great. Why did you join that group? What was it that was attractive to
That's
it?
a great question. If you talk to some of my family members, it says it's a baseline chemical imbalance, and some say I just hit my head way too hard when I was growing up. But in actuality, when I was doing my undergraduate work, I started working for the fire department and was doing some really cool EMS work, and I loved it. I loved the people. I loved the mission. I love the understanding, at least at that time, the basics, very basic and fundamental human physiology and I did really enjoy the excitement of it, and worked for the fire department and doing emergency medical work. And as my academics sort of progressed in parallel, what I realized was I was not ready to be an academic. I certainly was done with school at that point and didn't want to go on to additional, graduate school. And ran into several people that were familiar with the organization. And they're like, if you really like doing this stuff, you should check out this pararescue thing. And I was like, the Air Force, what? I'm like, no way. I don't like wearing a uniform. I don't like being told what to do. Like, I can't imagine the military being a good place for me at all. And it turns out I sort of started learning more about it. And I was like, this is amazing. They're going to pay me to jump out of airplanes and do cool emergency medicine work. And so I walked into the recruiter, and the rest is history.
And okay, so you had to do some exciting stuff, of course. Uh, Later on, because that's why I came to your work, you talked a lot about uh, mental skills,
Hmm.
maybe about regulating yourself. But when you did this training and became a pararescue, did you already possess these skills, or were they thought?
I think I don't necessarily think so. I think that necessity is the driving force behind so many things. And it wasn't until that I was really pushed to my limits. First in training, the selection process is very rigorous. And at least at that time, they were only, I mean, the completion rate for the pipeline is, I think my class started with 72 and six of us graduated. So we lose a very high rate of attrition. And the selection process is very rigorous. It's incredibly intense. So it wasn't until then that I, actually am literally like reading books and trying to piece things together about like how do you stay focused? How do you deal with,
Mm,
the stress, especially at least for us, the water confidence and some of the exercise in the pool and preparation for the combatant diving course was particularly stressful. I mean, you could be super strong, you could be super smart, you can be able to run from, you know, here to Antarctica, and that's all good and great. But if you take away someone's air supply and force them to be under the water,
yeah.
it's pretty physically and psychologically stressful. And so that was sort of like the first piece of the puzzle where you're like, there's much more to this than just physical endurance, the ability to keep yourself calm and limit your oxygen use and stay focused when you're running out of air. Um, Started to look into some of these things, and then not in a very academic way, just kind of like looking online and reading some books. And then what I realized that in practice, a lot of people did the same thing. So there was
Mm,
no formal training program in the military at that point. Um, Individual units sometimes would explore these concepts, but there was no military-wide or special operations command-wide training program. But what I noticed is some of the best people that I worked with, some of the most elite operators on the planet that I got to work with in Iraq, um, did the same thing. Like they
mm,
had these little routines. Many of them learned it or adapted it from sports, from athletics,
mm,
the way they did competitive athletics, and it adapted it to these situations. Because at least in that setting, there's no academics to it. It's whether or not you live or die, and that is a very powerful driving factor for improving your performance. The ability to stay calm and work through some of these very dangerous, very dynamic, incredibly chaotic. Um, Tactical situations. And I think that drove people individually to do this. And then the real epiphany came when I was actually um, we would go back from time to time stateside, and you have to do continuing medical education and training. And to the credit of the United States military, the Air Force, and SOCOM in particular, they sent us and paid to send us to some phenomenal training institutions, civilian training institutions, one of which was the University of Maryland R. Adams Cowley Shock Trauma Center in Baltimore. lots of trauma there. Brilliant trauma surgeons, anesthesiologists, and emergency medicine practitioners. Mainly, I was working with the surgeons and the anesthesiologists in their trauma resuscitation unit. Very busy trauma center, and I distinctly remember one day, one of the senior surgeons explaining to one of the junior residents some of these mental skills.
Mm.
Like he's like, you're going to be in charge of running this trauma. This is how I want you to think about it. Yes, keep in mind some of your ABCs, airway, breathing, circulation, recognizing that that's changing to focusing on, managing acute hemorrhage first, but he kind of put all that aside. He's like, yeah, that's all the academics of what you're going to do for this guy who's going to be here in 2 minutes. But think about this, take a deep breath. Think about how you're going
Mm.
to do this procedure. Because there's one procedure that's going to save his life. And this is how the procedure is done. I want you to imagine really quick in the next minute what you're going to do and what he's going to look like and how you're going to hold the scalpel and the steps. And I was like, oh man, this guy, this is a tenured trauma surgeon who I've been looking up to for the past 3 weeks, who seems to know everything about human physiology and trauma. And not only that, when it comes to the technical elements of doing these very invasive operations very quickly, these trauma resuscitative operations, the guys, it's amazing. Like watching, a professional athlete or watching a skilled musician. It's a thing of beauty. Here's this guy, and this is what he does.
Mm.
He's using the same mental skill set as um, some of these elite special operations guys, these 230 pound muscled out SF guys that are brilliant and amazing tacticians and phenomenal combatants. And then there's this trauma surgeon in Maryland who's doing the same thing. I'm like, there's something here. There's absolutely something here because these very high performing guys who have never met each other from very discrete disciplines, one very academic, one very non-academic, they're essentially doing the same thing. They've adapted the same mental skill set. And that was pretty powerful.
And is it today? Is it taught at military units explicitly? Because there is some. I heard Navy SEALs, Big Four, whatever. In here in the Netherlands, there is some movement towards mental skills, like in the whole education program.
I
How is
think
that
there
now?
is. It is definitely gaining momentum and becoming more popular. It's been around in some circles. I mean, certainly before I ever heard about it or looked at it. But the I think issue is that it hasn't been explored scientifically to really
Yeah.
suss out what works best and what doesn't on the military side. It's been very isolated and siloed institutionally. So you may have some people in the Navy or the Army being like, oh, our unit did that. We've been doing that for a while. Or we've been writing about that and teaching that for a while. But it's very um, inbred is the wrong word, but it's just sort of specific to their organization and hasn't really grown or expanded to incorporate the um, the most recent evidence or data.
Mm.
And furthermore, although I think it kind of begins to evolve in line or in parallel with what other people are doing, it becomes somewhat dogmatic because it's just handed down from one person in the group to the next person in the group. And sometimes, surprisingly, it's not cross-pollinated across disciplines, across services in the military.
Yeah.
So it's getting there, but still got a lot of work to do.
Yeah. And you did the work because you came up. You published some papers about mental skills training. I think it was in your medical career where you then.
Yeah, just when I was starting, and even
Yeah.
in medical school, we were writing about this and trying to apply some of these concepts, which is absolutely fascinating. And I think um, the medical world in particular was way behind in a
Yeah.
lot of these concepts, more so than a lot of other disciplines.
I talked to a surgeon here in the Netherlands, and I asked her about mental skill training, and then she said, Well, she said, when I'm operating, I don't need it because I know what to do. It was such, and I talked to another great surgeon here from the Netherlands, and he he was very interested.
Hmm.
Because he had given his operation room for a study group for performance
Hmm.
psychologists. But
Hmm.
he also told me, he said, well, I guess I'm doing something good, but I leave it to the psychologist for the mental skills training. So it's also here a little bit. But you came up with a great acronym. I have you formulated the beat the stressful, and we use it in our 2 day program for the ambulance and for the medical specialist.
Nice, yeah.
And how did you came up with that?
It was sort of a practical, it was sort of I try to take a very practical approach to things and get very granular on some of these ideas because I think some of the challenges, some of the barriers to get it across the medical into the realm of emergency medicine has been not not the lack of attempts because there's certain there. I mean, I've seen. I mean, even in our program here, I teach the stuff, develop the stuff, and write about this stuff, and people will bring into some of the pre-hospital services here people who talk about these things, mental skills and stress and whatnot. And they're very nice people. They're very good. They're certainly very professional and adept and know their research base. But it's a psychologist who's never stepped outside of their office. They don't know what it's like to be on the street. They don't know what it's like to be working as a law enforcement officer and being confronted with very dangerous individuals. They don't know what it's like to be in the back of an ambulance or the back of the helicopter at 2 a.m., working with someone working tirelessly, feverishly, so quickly to save someone's life when they're on the precipice of
Yeah,
dying. And they certainly don't understand the combat environment or anything like that. And so their recommendations, although sound and grounded and reasonably good science, are completely not appropriate or applicable. Like, I can't land on scene in the helicopter and get out and be like, okay, everybody, I need a couple minutes. I'm gonna roll out my yoga mat. I'm gonna ground myself. I'm gonna, do some meditating, and then I'll be in to save this person. Yeah, as they're like, very, like hurriedly trying to breathe for the person. There's blood
yeah.
everywhere, and they can't breathe, and their oxygen saturation is in the toilet, and you just can't do that. It's not practical. And so I think it kind of came from looking at all of the science that had been done to date and coming up with a handful of simple skills that were low-hanging fruit with reasonable to strong data behind them, and you could do that fit into the workflow of someone who is responding to an emergency um, in the military, in the emergency medicine world, or elsewise. And I think that was the key. Was we just kind of looked at it and we were talking to one another. We're like, could you do this skill like as you're flying out to a scene? Could you actually do this, during um, an engagement that necessitates the lethal force? Like, could you do these things? And if the answer was no, we just didn't even bother looking at it. It could
Yeah.
great ideas. It didn't fit into the framework of how we function. It was essentially useless in that sense. So I think that was how we went about it. We tried to be very practical.
And the be the stressful was about breathing. The S was for seeing. I think that this is mental rehearsal,
Yes, exactly.
self-talk, and the last one we struggled a little bit with in the stressful. It was the F from it was
Focus. Yeah.
focus. Eh? Yeah, yeah. Has it evolved since then? Your thoughts
So
about it?
I still, as much as they've tried to evolve, and I have, I think, because I try to incorporate this in my practice every day, in the emergency department, in the ICU, and although I haven't been had a lot of time to fly recently, when I do get on the aircraft and fly, um, I still keep coming back to those essentially those four elements. Now, that might just be my bias because I was using a lot of those before, and as those individual four things have sort of evolved for me, I have simply failed to move beyond them or incorporate other things to make it 5 or 6 things. Um, but I just keep on coming back to those 4 things in this particular setting being the most useful.
And maybe can you give me some feedback on my thoughts about it, if you want?
100%, absolutely.
So I'm struggling. I'm struggling with this because, as you said, you have if somebody is shooting, Bill Lewinsky wrote about this. If somebody shoots at you, there is no time to breathe. Yeah, of course you breathe, but you cannot do the box
Mm.
breathing, and so on. And so I came up with a kind of thing. It depends on the time scale. So you have like your daily life, then you have the pre-phase where you can you can drive into an incident, you can do some form of breathing, but during the resuscitation, what, resuscitation, is it correct?
Resuscitation,
Yeah,
yeah.
resuscitation. Maybe box breathing is too long and you can do an extended exhale. And afterwards for recovery, you can do, but what do you think of that framework? So to make it more different things in different phases.
I think that's absolutely reasonable. I think first and foremost is any of these skills have to be adapted to your workflow, your function, and how things go. And I think one of the things that I've realized is that a lot of them are really dynamic, right? So take somewhat of a classic pre-hospital response to a cardiac arrest. So the example that I give people. Um, there's the somewhat of a preparatory phase, so you're responding at that point. Like, let's say you're not the one who's actually driving or flying the aircraft, as it would be, but you're a passenger. You're getting ready, right? At that point, you're not doing anything. There's aside from the stimulus and thinking about stuff, there's not a sick patient in front of you, and you have some time to do essentially all these things. You get on scene and people are feeding you information. You're using that working memory and cognitive load to process information, and you're really not doing some of those skills. Um, if you go to execute a specific technical skill, hopefully you've done some of the mental practice and whatnot on the way. And even some people can train themselves habitually to, as they know what they need to do, as they're pulling the parts and pieces out of their bag to be able to rehearse it. But by and large, you're not walking through a lot of that BTS stuff at that moment. Now, that cardiac arrest evolves, right? You get on scene. Um, there's someone doing chest compressions. You're breathing for the patient. You're doing all this stuff. You're trying to figure out, why they arrested in the first place. Where are we going? What resources do we need? Is this person a candidate for extracorporeal support, et cetera, et cetera? Um, but I think we can all agree, you reach this plain phase when the cardiac arrest where you're giving the medicines, you're breathing for the patient, you're doing the chest compressions, then you're monitoring for arrhythmias that are um, amenable to defibrillation. In that phase, after about 10 or 15 minutes, everybody's got their part. You're just all kind of standing there trying to make a decision. And that is another great point to take a deep breath, think about some of these things, and execute some of these individual mental skills because you're transitioning from a very high workload, making sure
Yeah.
we got everything done and doing everything to this sort of planed out um, steady state, if you will, resuscitative steady state, where you have a moment to collect your thoughts, calm down, use some of these mental skills. So it's very dynamic, right?
Yeah.
The course of a lot of these resuscitations, even if it's in the hospital, it's not always rushing to do life-saving skills. You're often intervening and then backing off. You're showing up to the ICU room and someone's hypoxic and altered and you have to intubate them and you intubate them and despite your best efforts in doing all this stuff to manage their hypoxia and their blood pressure beforehand, you intubate them and now their blood pressure is really low and so you step back from doing the airway management piece of things. You're at the head of the bed and then you're doing other skills and thinking about things and perhaps transfusing a patient or doing point of care ultrasound to kind of figure out what's going on as far as their hemodynamics are concerned, and then you figure it out and you treat it and then something else happens, you take a step back and use some of these skills again. So a very
Yeah.
dynamic dynamic flow.
And how now I try to frame the question objective, but I think I failed. Uh, But how important is the recovery phase? And I mean really on a physiological level, like from moving from a high sympathetic state to a rest state, especially as a doctor. And my wife is a doctor, and we talk a lot about it. And she runs from one patient to the other patient. And if I talk to doctors in the hospital, it's the same. There is also no real time for debriefing and so on. But how important is the switch off between patients? Is it important, or is there no time? What do you think from a mental and physical health perspective?
Oh, so that's an amazing question. And I think this is perhaps we're giving more and more attention to a lot of these different efforts when it comes to mental skills and whatnot. And a lot of it's focused on I think the highest level of excitement, the highest load early on, the highest cognitive load early on, or at least that's where I've focused. But it's funny you mentioned that because I was actually talking to several very smart people in health science. So I'm finally, after years of medical training, trying and I was in very good health and very fit in the military, and then went into the hospital for a long period of time, and have worked 80 hours a week for years now. And now I'm finally trying to focus on my physical health and getting back in really, really
Yeah.
good shape. And in talking to, we were having this conversation about some of the data behind, um, muscle building and healing and tissue growth and all these other concepts in the health and fitness and physical therapy world, which they're just fascinating, cool stuff to me.
Yeah.
But how to optimize that. And we got onto this exact topic of it. Well, the muscle stimulus is important, and we always focus on the gym and the exercises you're doing, and or the cardiovascular workload in a run or a hike or some effort, physical effort, right? But perhaps what goes, which is not as exciting and not as work task focused, is the recovery phase.
Yeah.
How you sleep, how you eat, how you relax in immediately after, for example, going to the gym,
Yeah.
what you do in the hours after that, and then that night as you rest and recover. Now, I think that's fascinating, and it kind of drew me to the same idea of, well, from a mental skills standpoint, that's that is under addressed. We don't
Yeah.
look at it enough. And while some of these individual skills, like the BTSS stuff and many others, focus on bringing the level of stimulation and inducing calm and focus and a lot of these other skills in the moment, there may be some application for them and other skills. This is where you can really broaden some of those mental skills because you're not treating someone who's dying. It's not an emergency. You have perhaps minutes, but sometimes hours, um, or even days to recover from these situations. Now, again, it's very hard because um, you can't, if you're an anesthetist or an anesthesiologist working in a busy ICU or between the operating room, you can't be like, okay, well, this person's dying and they can't breathe, or we have to go emergently for this big operation. But just give me a couple seconds. I'm going to go to the chapel, or I'm going to go to a quiet space, and I'm going to meditate. Right? You just can't do that, because these people need our help, and they need our help when they need it, not on our schedule. And the workload, whether you're a law enforcement officer or a paramedic or nurse or doctor, is not determined by us. It's
Mm.
determined by the needs of others. We're in a service-driven career fields, and so I think it's not a question of. It is a question of, is it important or not? And I think it's important. I think a lot of us can agree that it is important. Operationalizing those skills and creating mini recoveries or micro recoveries in between very stressful episodes, in between seeing some of those patients, is important. And then continuing to drive home to people that the mental recovery and organization and dissection of what happened to improve your skills moving forward in that period of relaxation and recovery is very important. I just don't think we know A, to what degree, B, how to do it very well in both instances, both the running from patient to patient and the, okay, it's the end of my shift, I can go home and relax. Um, and then especially when it's perforated chaos, a resuscitation, and then you have, 15, 20 minutes, you're finally going to get a meal, and then you get called again and you're running to another right bedside of another patient, or, you get toned out for another call after you just got back from one. And that those periods of stimulus and recovery, when the recovery time is very short, how do you do that?
Yeah. At the military, there is currently a project about mental fatigue, and how to combat that. I would like to come back to that, but before that, Dan Dworkish talks about the difference between self-sacrifice and self-destruction as a doctor. And
Hmm.
me and my wife, we talk about. She says it's so strange. I'm a doctor. I give health advice to my patients, but I'm working so hard that I have no time to go to the gym myself. It seems so paradoxical. And
It really is.
what
And I
what
think we haven't.
what needs to happen to
That's a great
change?
question. And I think both in training and in practice, we have to come up with some way to do that better. And I honestly, that's the thing I struggle with on a regular basis, because between, my personal health and fitness, work and family, balancing those things is obviously very important. Sometimes that balance is dynamic. It's heavily on family, or it's more heavily on work and whatnot. And the self-care, I imagine if it's the same for other people, kind of like it is for your wife, tends to suffer. And I just don't have I don't certainly have a good balance for it at this point. And I don't know how to do it other than um, trying to trying to think outside the box to find novel ways to balance that. I think the way that healthcare, at least in this country, going is certainly not going to be, less work. Perhaps we could work more efficiently on like the learning side of things and professional development side of things. Certainly, at least in the United States, once we get a training, that balance seems to shift in terms of the clinical workload. You're certainly not working as much, and you have more time to do research and other stuff. But as we mentioned in the beginning of the pod, or we were talking about before we started the podcast, right? We're busy people and very engaged. So that time tends to fill up very quickly with other stuff.
Yeah,
We tend to stay busy, and perhaps that's not the most healthy thing. Um, but it's incredibly difficult, because I think for those of us who are driven and very focused, like, you want to be good.
yeah,
And so, like, you stay up late reading articles about, like, this really didn't go very well today. What don't I understand about liver failure in the setting of trauma? What don't I understand about, mechanical ventilation for this particular patient? What don't I understand about coagulopathy and hemorrhage control that I'm missing? And that's a hard habit to break for those of us who really care about our patients.
yeah. I love Preston Klein from the Mission Critical Team Institute. He talks about the third thing
Hmm.
between work and family, like do something, if even if it's drawing or music, whatever, but have something also in place where
Hmm.
you can, you know, uh, come out as stimulus response mode.
That's a really good point.
So
Yeah, I think it's how we do that that's going to
yeah,
be really challenging, right?
and last point, Mike, before we go to the decision making, um, there is within the Dutch military now, so there is some attention for mental fatigue, and we came to the same conclusion. You have the mental fatigue, between the days, but you have also the mental fatigue recovery between a training block and a training block. And then you have on a micro level, maybe, like going from rest and control, 10 seconds rest, what can you do? But mental fatigue, did you study that? Did you study that? So I'm not sure what mental fatigue is, because it's a definition question, but I can imagine getting your workload, your working memory. What about mental fatigue? Did you study it?
Yeah, so really good question. So we have not really, it depends, right?
Hmm.
Because again, there's no universal definition. It depends on what you're talking about and
Yeah.
when. Is it chronic? Is it acute? Um, and I think that we haven't really explored that, but I think it's an area that we need to. And the reason being is, again, very interesting you asked this question because we were recently having this conversation, and the analogy that we kind of were thinking about, because we were chatting about it, one of my friends noticed their phone was dying, and on their iPhone they looked at like the battery life thing, like it's fully
Yeah,
charged, and then as you go through the day, you're Googling a whole bunch of stuff and talking to people and texting people throughout the hospital on your phone about different patients and stuff, and you watch the battery life go down really quickly, and then it kind of levels out, and then you're done with the procedure, you pick up your phone again, the battery life goes down, and then you may have periods throughout the day where you're like, oh my gosh, my phone's going to die. You plug it back in, and then it recharges a little, and then you have to run someplace, so you take your phone off the charger, and you're going, and so the battery life just kind of does this, and then maybe it charges a little bit, but until you go home at night and plug it in, it doesn't fully recover.
yeah. That's a great
And
analogy.
furthermore, over time, right? I don't know if anybody else has it, but when you're constantly completely draining and then charging and draining and charging your phone over the course of years, right? That battery life doesn't work so well. The interesting thing is, it depends on it also, none of those individual mental skills are discrete or isolated, right? So certain cases or certain calls or certain patient experiences or interactions, right, may be very draining from an emotional standpoint. Talking to a family about someone who's really not doing very well or a sudden and very unexpected accident, that drains your battery a lot. But it's fundamentally very different from other draining
Yeah,
things like a prolonged resuscitation where you're using your brain to actively make decisions and clinically focused decisions on therapeutic interventions. That's different.
yeah,
So my surgical colleagues have explained like it could be a relatively simple procedure, a very a very well designed, well circumscribed procedure. But then when you get into the abdomen, it's a disaster. Like it's very complicated anatomy. There's lots of scarring tissue, and what otherwise was a simple procedure turns into like a marathon,
yeah,
which is exhausting in another way,
yeah,
right? So I think there's a lot of different ways to dissect
yeah.
it out, and we haven't codified those very well. And then looked at those things on a minute to minute basis, hour to hour basis, day to day basis, and over the course of years. Um, but it's absolutely a thing, and in certain circles, it has been reasonably well defined for a specific area.
Mhm.
Um, Decision making fatigue, for example, is a
Mm.
great one that has been explored, and it's been explored interestingly in multiple venues, right? So like looking at some of the psychological literature, looking at decision making fatigue, like if simple things like your ability to make healthy decisions about what to eat.
Yeah,
Mine are great on a stress a stress-free day. At the end of a long day in the ICU, I'm like, whatever's available, right?
yeah,
You're just so fatigued
yeah,
from making all the decisions that you'll eat anything. And I think that's fascinating stuff that we need to explore, especially in the emergency medicine
yeah.
pre-hospital side of things.
Great. Talking about decisions, what is I'm not sure, Sinefrin is David Snowden's framework. How do you spell it? Sin,
Yeah, it is spelled Cynefin, and it's pronounced. You'll have to forgive me. My Welsh is a little rusty. Uh, Cynefin or Cynefin, which is again not how it sounds. So for those of us who in the English speaking world, the United
yeah.
States often are challenged by that.
And I told you I talked with Von der Pleen from For Science Institute. He talked about it with police officers. You came up with this topic. What is so fun and what is so great and important about this framework? What is it,
Oh
by
my
the
gosh!
way?
So.
Yeah,
So this is really fascinating. And it's been around for a while, but again, it's one of those things that like if you grow up in medicine, right? If you go to undergraduate and then graduate school, and then you go to a residency or postgraduate training to be an anesthesiologist or surgeon, like you just sort of grow up in an institution, and very rarely do we like look outside of our institution or the medical literature for cool and interesting things that explain the world and explain the way we work. And so a friend of mine who is a flight nurse and also got into the business side of things exposed me to this several years ago, and sort of sat on the back burner simmering for the past 3 or 4 years. And as I've read more about it and explored the topic, and believe me, I am far from being an expert on this particular topic. So forgive me, and I'm sure some of your listeners also probably know more than me about it. But I'll sort of give my best adequate description, as is my understanding right now. Is It's essentially a framework for understanding and making decisions in complex, complicated, and chaotic environments. The thing I love about it is when we think about decisions or decision making in clinical medicine, pre-hospital medicine, it's very complex, it's very complicated, and it can often be chaotic. And the way we make decisions about therapeutic interventions, as outlined in the literature, is often algorithmic,
Mhm.
and is often, like in bubbles, if they do this and their biomarkers are like this, or their oxygen saturation is like that, then do this. And if not, do that. But that's not the way our brains work. Furthermore, it's very simple when you contextualize it, and there's one thing, one system. The patient comes in and they have one very obvious problem. That's simple and reflective of those algorithms in literature. But the time course can also be very truncated. They can be very sick. Things can be very time sensitive. They are often have multiple things going on with them. And much like the military and tactical environments, you don't have all the information. Things change very quickly. In fact, sometimes they change faster than you can even process information, right? And when you have a biological system that doesn't always follow the rules, because the rules weren't written for people with complex infections and heart failure and kidney failure and something else, right? There's no guideline for that. What do you do? And I think our friends in the world of decision making, and David Snowden in particular, took a look at this and exposed it. And they specifically say, if you like read some of their literature and something, it's not a protocol, it's not a guideline, it's a framework, it's a way of
Mhm.
seeing, it's a lens through which you can see the world and see how we make some of these decisions. And what I love about it is it. Um, it is flexible and sort of very all-encompassing, and that a lot of things, what I tell people, for example, is the classic intuitive versus analytical decision making, right? We've looked at that for a long time as black and white, as you know, um, one versus another, as very distinct and opposite poles in the decision making world.
Mhm.
Um, but if you really get into it, even um, even the very strong proponents of either one of those. So take, for example, some of a couple of the people that I very much look up to in this world. Um, you have Gary Klein, who's written a lot about insight and intuitive decision making and recognition prime decision making, and that's his whole thing.
Yeah.
And then you have people like David Kahneman, who have wrote the book Thinking Fast and Slow,
Yeah.
and we're clearly very big proponents of an analytical way of thinking about things. They're not mutually exclusive, and in fact, they wrote a fantastic paper
Great. Failure to
where
disagree.
they
Yeah.
exactly, yes,
Yeah.
exactly, right,
Great.
where they
Yeah.
come together and they're like, well, it's very situationally dependent.
Yeah.
And there are some systems where recognition prime decision making works, others where it doesn't. So, in very scientific confined symptom or situations where you can reliably, the situations are reliably reproduced, they follow laws of physics and chemistry. Where you can perturb the situation and you get a response with very clear and reproducible effects, right? So, for example, in the medical world, you have someone and they have an arterial catheter in and you're measuring their blood pressure and you give them some epinephrine and you watch their blood pressure and heart rate go up. Very reliable and reproducible under almost all circumstances. Versus from a strategic side in the military, right? When you're dealing with thinking about what other people are thinking about, knowing that they're thinking about what you're thinking about, these very higher level strategic decisions, they don't apply any of those rules. And you really have to analyze things and think about statistics and likelihoods and all these other things, which driving people. Gambling is another great example of that,
Yeah.
right? And they use those in their books and literature.
Yeah.
And they came together and in that paper, which I encourage everybody, all of your listeners should read it, Failure to Disagree. The thing that I loved about Cunevin is that it brings a lot of these concepts together
Mm.
and incorporates a lot of these concepts into a structure that I find is something that we do every day. And so I can try to outline it basically from a
Do do
decision-making
do do you do
standpoint.
you do you have like a, how do you call it? Can we put up on a photo of the framework or the quadrant? I'm not sure.
Yeah, so I think that you can actually pull up one of the images, even if you Google it right
Yeah,
now.
where we have to.
And yeah, if you just look up Cynefin framework, so Cynefin, you can sort of see their framework or model that they've proposed, which I think is fascinating. But it outlines pretty well.
Do you have one on your screen, Mike, or not?
Yeah, I'm pulling it up right now. Yeah. Would it be helpful if I see if I can?
Yeah, you can uh record. You can share it. But I'm not sure if you're authorized. Authorized. Yeah, great.
Yeah.
Yeah, great.
So this framework, for example, um, I really like because it explains, at least in clinical medicine, my thought process and the things that are important and how we sort of go about making decisions. So I'll take some liberty here, and David Snowden will have to forgive me, and a lot of the Cunevin people have to forgive me if I take a little bit of liberty with their framework model here as I apply it, but. So they start out with obvious or simple solutions when things are clear.
Yeah,
So if someone comes in, they've been they've been hit in the right side of the chest with a baseball bat. They have multiple broken ribs. They have subcutaneous emphysema and air leaking out of their chest, and there's an obvious pneumothorax. And then they drop their blood pressure, and they look like they got a tension pneumothorax. And it's pretty obvious. It's pretty
yeah,
straightforward. We can all agree. There's a simple solution to this problem. Like we know we have to put in a chest drain of some sort. We can argue about what you put in, but you only need to drain the air out of the chest, right?
Mhm.
I think David uses the example of it's like driving in the UK versus the United States. Like in the UK, we all know we get there, we drive on the left side of
Yeah,
the road, right? That's what
yeah,
we do.
yeah,
Everybody understands it. It's a simple practice. We all kind of go with it. Another example of in the ICU in the emergency department, for example, is someone who comes in with type 1 diabetes and diabetic ketoacidosis. There are very simple protocols for it. Once you identify it and diagnose it, we all agree what we got to do, right?
yeah,
That's obviously not the minority of the decisions and issues that we have. And then we have complicated decisions or decisions in a complicated domain where these are complex patients. For example, they may have DKA, but they may also have chronic obstructive pulmonary disease, and they're breathing kind of fast and they're hypercarbic because they haven't been taking their COPD medications, but they also have heart failure, and so they have multiple things going on. Right there, this is a complicated situation. None of the individual discrete evidence-based guidelines for managing any of these discrete pathologies incorporates the other pathologies. So there's no guideline for DKA in the setting of COPD, which also might be a heart failure exacerbation,
yeah,
right? In these situations, They talk about the paradigm of sensing, analyze, and responding. Like if something's simple, you just look at what you're doing and it's very intuitive. Like you have the information and there's not a lot to analyze. You kind of know. You've seen the pattern before,
Yeah.
everything matches up, you do it. In the complicated decision-making domain, um, you really have to think about things. You have to get more tests. You have to analyze those tests very carefully, talk to other discrete experts that may understand these things and say, hey, do you think this is more like I did this bedside echocardiogram? Is this really a worsening of their um, heart failure, or do we think it's more COPD and specifically in the lungs? And then if it is, like, how do I manage the DKA? And so
Yeah.
you put these pieces together with multiple experts, and then informed by evidence, you come up with a reasonable solution,
Mhm.
right? The complex situations are even more complex. There's no clear answer.
Mhm.
I think of them as being more time sensitive, and you're really not sure what to do. All of the
Mhm.
diagnostics, none of the tests that you do have good evidence in a particular area. Or in this particular scenario, you have multiple things going on at the same time. So, a sick patient with an infection plus ARDS of the lungs, so acute respiratory distress system syndrome, and also right heart failure from some interaction of these things is making them so sick that none of the individual discrete diagnostic tests may have validity, or there may be a clear answer. And in these situations, their suggestion or the paradigm for making decisions here is probe, sense, and then respond. So
Mhm.
getting back, this sounds a lot like an OODA loop, right?
Mhm. Yeah.
Um, and how we orient to these situations is dependent upon whether it's simple, complicated, complex, or chaotic. The
Yeah.
orientation here is you just kind of probe the scenario. So you test the biological system and see how it responds. No one really knows. We'd come up with a safe plan. For example, give them a medication or give them some fluid, give them some resuscitative fluid, blood, crystalloid, whatever. And then you watch what happens. You hypothesize, well, if I give them this fluid, I think they're intravascularly depleted and I think they could tolerate it, but I'm going to watch what happens. Watch what happens to their blood pressure on the arterial line. I'm going to do a bedside echocardiogram. I'm going to watch what happens to their heart. Does their stroke volume improve? Does
Yeah.
this happen? Does that happen? Do things get worse? I don't know, but I test the system and I see how it responds.
Yeah.
It doesn't respond very well, or something bad happens, their blood pressure drops, their cardiac output drops, their oxygenation drops, you made the wrong choice,
Yeah.
right?
Yeah.
Um,
Constantly
uh,
feedback. Yeah.
exactly.
Yeah.
And based upon how you perturb the system, you get that information back, and then you proceed in making decisions. And it's a very dynamic, very falls very nicely into that OODA loop time
Yeah.
sensitive sort of decision
Yeah.
making cycle. And then there's those incredibly, incredibly chaotic situations where it's so time sensitive that there's no clear answer, number one. It's so time sensitive that you really don't have time to do much thinking or
Mhm.
do much probing. You simply act. So people say this is ridiculous in medicine. You can't just act. You can't just be reflexive. But if you think about it, we do it all the time, right?
Mhm.
Another great example is cardiac arrest. We don't sit there with the patient in cardiac arrest and we all like fold our hands and, well, what caused this patient to be in cardiac arrest? Right? Was this or was that? I wonder why they dropped dead here on the street. Let's think about this. No, we don't do that, right? You immediately begin resuscitative interventions, and then you later on, at once things are sort of stabilized or you're doing the appropriate recommended interventions to try and resuscitate this patient, then you think about it, right? But in that moment, it's so chaotic and you don't have the data, you don't have the information. All you know is, okay, they're not breathing. They don't have a pulse or they have no effective perfusion. We're going to start CPR. I'm going to start chest compressions and do all that stuff. And then we'll get some feedback and we'll get some diagnostics. We'll put the monitor on them. We'll suss it out. Um, Same thing in like a tactical situation.
Yeah.
If you're crossing a road or you get off an aircraft and someone starts shooting at you, we don't have a caucus. You don't sit there and be like, I wonder where they're at. I wonder why they're shooting at us. Like, what's
Mhm.
going on? Like, what are they shooting at us with? We don't analyze the situation, but we drill this. So you instinctively, intuitively essentially revert to that very ingrained psychomotor program of return fire, bound back, get to a safe space where you're not in imminent threat of being shot in the head, and then you can begin to come up with a plan and actually work through the tactical problem, right?
Yeah. Yeah.
Um, and so this framework, I think, explains, at least in my mind, the process of decision making in these situations, both from a tactical perspective and from a medical perspective, really well, like shockingly well.
And how can doctors use it to make it
Oh,
really hands-on? Yeah.
so that's a fantastic question, and I'm still working through it myself to kind of figure out how I can explain it to physicians. Um, I think one of the most important things that I tend to get across, or trying to explore and explain to people, is this idea of the complex. That it's okay under some circumstances. You don't have to know everything, because I feel like we're constrained in medicine. A lot of the time we don't fully understand the situation, or there are various services or people hypothesizing, well, I think this person has more. I think it's more heart failure, or no, I think it's more COPD, or no, I think it's more this, or no, I think it's more that. And they will argue one way or another based upon the diagnostic data that they have available to them, what the problem is. And when you get to that point, a lot of the times there's no clear answer. And sometimes it's reasonable and appropriate to try something that's safe and reasonable to perturb the system and say, well, we're going to try this drug, or we're going to try this approach, and we're going to reevaluate it in 30 minutes or an hour or tomorrow. And then we're going to see what happened. And then we're going to make decisions based upon that. That, I think sometimes people are so scared to do something, perturb something,
Hmm.
make a change, try something that's reasonable and safe, and often with informed consent of the patient and the family and all these other things, to try and solve the problem, that the problem just goes on. You mentally go back and around and get stuck in this very, you're paralyzed by the analysis, paralysis by analysis.
Yeah.
You never make a decision, and then you never move forward because you're too scared to do the wrong thing, or you're
Yeah.
too scared that something bad might happen. As opposed to, some situations are so complex and bad things are going to happen, that taking a safe and reasonable approach and trying something to get data back and then make a decision is, in some cases, looked down upon, or discouraged, which I think is not good.
And is this quadrant of the complex, is that the most important lesson for doctors, or is there in the other quadrants, are there also lessons to learn for doctors?
Really good question. I think the most important lessons are here. This is my
Hmm.
personal opinion, no data
Yeah.
on this. I think the most important lessons in acute care are going to be here. This is the area I think we know, arguably, we know the least about, when it comes to decision making, and is probably highest yield to explore. We've talked about complicated before, how to move through these things. These are academic discussions we're used to in medicine, getting tests and analyzing them
Yeah.
and working through complex, not time sensitive situations,
Hmm.
right? We're less adept at complex, time sensitive situations, where we're actively probing and coming up with information and data, and working through those problems quickly. So I think this is probably the
Hmm.
area that, is the biggest question mark in my mind, and I think we should explore.
Great. Von Klim from Force Science Institute, from law enforcement, he talked about this framework, but more in the sense of, if I'm correct, but I can totally be wrong. uh,
Hmm.
uh, he told me that when an officer is going to court, the outcome is already known. So they judge the officer based upon knowing the outcome. For example, there was use of force. And if I remember correctly, his point of view was that if you are in the complex or novel situation, you don't know the outcome. So
And very true, exactly.
yeah, so then you are, going to OODA loop or doing trial and error to get some feedback, but you are not at that moment, you are not sure. And afterwards, of course, with hindsight, you can say it was this, but yeah,
Yeah, you have um the benefit of the retrospectoscope, as we like to say, being
yeah,
able to
yeah,
see what the end result was. Yeah.
yeah, yeah. And how because you started with within this model, you can also how do you call it? Harmonize the different approaches like Klein, Kahneman.
hmm
Uh, what does that mean practically?
Yeah. So that the union, or I guess um, coming up with or incorporating them both into this model makes sense to me, because
Yeah,
there are times when analytical and times when intuitive decision making work really well. For example, if you have a patient who's not actively dying and they are very complicated and you have a lot to work through and there's a lot of diagnostic tests and you need to get it just right, right? Um, the complicated domain explains that very well.
yeah,
Why we shouldn't just be knee-jerk reacting and using recognition prime decision making for everything, because you don't have to all the
mm,
time. And sometimes doing that may be more harmful than really stopping and thinking about things. Whereas, for example, in the chaotic domain, reflexive decision making,
yeah,
recognition, prime decision making, identifying and quickly reacting to a situation is could potentially
yeah,
is better and safer, because the risk of waiting and analyzing and thinking could lose you the 2 seconds, the 10 seconds, the minute that you needed to do something. That
yeah,
window could be gone, and that could affect your safety, your colleague's safety, or your patient's safety, right?
yeah.
And so this framework incorporate or has allows space that that you can see where these different decision-making models fit in very well and appropriately and are not mutually exclusive.
And to end this topic, if what is your plan? What is your ambition with this framework within medicine? What would
Oh,
be
so yeah. So my ambition is to first become a really good doctor. I still have a lot to learn
yeah,
from a clinical perspective, but in the realm of critical illness and injury, both in the military and the civilian side, from along the spectrum or trajectory of care, from small outside hospitals or from where people are living in very rural areas or even urban areas, through their initial resuscitation management and critical care, through that initial acute phase until they are doing better and on their way to rehab and rehabilitation and getting better. Through that entire trajectory, figure out where, when, and how we apply these different decision making frameworks,
mm,
or if we apply this decision making framework and overall, how do we train people to do it?
yeah,
When, which clinical situations are most appropriate? How do we label these clinical situations complicated, complex? Some of them are very obvious sometimes, right? Cardiac arrest versus like the simple DKA example that I gave. But I don't think that's been sussed out very well. And I think that we have so much to do along that entire trajectory of acute illness.
great. To ask one more question, which is almost almost too difficult to answer, but this is about decision making.
hmm
I recently had a police trainer who specialized in the OODA loop, and he told me the orientation phase is the most important. But what do you think of the four? Is
Yeah, I
decision
love it.
making is decision making the most important? Can you even say that? Of course, it's
Yeah.
dependent
So
on.
I think what's interesting again about this framework is it kind of like brings things together for me. I think the OODA loop is often interpreted in the setting of because Boyd developed it from a fighter pilot standpoint, right? We
Mhm.
often think about it within the context of very fast moving tactical air combat situation, right? Or for us, like a resuscitation or a law enforcement interaction or a combat situation on the ground in the special operations community. However, I think there's more to it. And I think that orientation phase fits relatively nicely within this framework, right? Because
Mhm.
orienting is all about essentially figuring out which domain you're in and where you're at. Because by observing, if you observe a chaotic situation that you need to make decision now, that orientation phase is very short, very abbreviated, and very intuitive. You move immediately to making a decision and then acting, right? Whereas if you think about it, that orientation phase, which I agree is probably the most important, if you have a complicated situation where you have minutes or perhaps hours, perhaps that orientation is longer, more drawn out, and more analytical than it would be in like a chaotic domain or a
Mhm.
very complex domain where it is very time sensitive. And so again, I think, and perhaps again, this is my bias, understanding and thinking about these things on a regular basis, is this framework um, incorporates, in a sense, incorporates or at least fits very well, dovetails very well with that OODA loop model.
Great. So we want flexible decision makers.
Exactly.
Yeah,
100%.
yeah. Well, great. Thank you so much. Did I forget to ask you something? Because we talked for a long time
Yeah, we
already.
did, didn't we? Oh, it was such a great discussion that I kind of got lost as it in the timing of things. But I don't think so. I mean, we could go on talking about this for days and weeks.
Of course.
But that was a really awesome conversation. So thank you so much for having me, Eric. I really appreciate it.
I really appreciate it also. You also gave some good advice for reading an article, Failure to Disagree, Klein Kahneman. And as we all know, Dr. Kahneman has recently passed away. And
Sad, very sad.
yeah, there are some giants passing away.
Yeah.
Yeah, yeah. Any other books doctors or military trainees should read for
Oh man, it is a
inspiration?
very long list. Maybe we should just
Yeah,
come up with a list and put it in the show notes. The
yeah.
list goes on
Let's
and
do that.
on.
Let's do that. Well, thank you so much for your service. Thank you so much for this conversation, and we keep following your work. And thank you so much. I will put a stop to the record and say goodbye. Thank you, Michael.
Oh, you're very welcome. Thank you, Eric.